Pinhanda, everyone, good afternoon, and welcome to our live webinar on how to approach abnormal liver function tests. So without further ado, I'd like to introduce our speaker today, Dr. Ian Rees, who's a consultant gastroenterologist for Howell Health Board. He has particular expertise on liver disease, and he's going to update us now on how best to approach liver function tests. Thank you, Ian.
Thank you, Nicola. The title that's been given to me isn't the title I would have chosen, and hopefully that I'll explain that as we go along. So the title I've chosen is Approach to Abnormal Liver Tests, and you'll notice there's one word that's missing, and hopefully during my talk you'll come to see why I've left that letter out now. So I think what I'm going to try and convey to you is my personal feelings. I was slightly reluctant to give this talk because I appreciate the audience is from around Wales, and there are my ideas and the All Wales ideas, and they're not always the same. So I've tried to give a party line on this, but also with some slight changes. So I'm going to talk about what are liver, I've used the word liver function tests, hopefully that'll be the only time that appears there. Which tests are useful, for what, how do we interpret them? I put some guidelines on, which I think part of the reason this talk is always asked for is because the guidelines are confusing, contradictory and multiple. There are some cases, but to be honest with you, I don't think we'll have time for the cases, but if we do, we can. They're just simple stuff really that we come across routinely. So what we call liver function tests are really not really liver function tests, they're liver tests. So what do we measure? We measure things like ALT, AST, so they're the transaminases really, alkaline phosphatase, gamma GT, bilirubin, but they're not really functioning tests. They're not measures of the functioning of the liver. They are tests associated with the liver and associated with many other things. If you ask me if I wanted to assess my liver function at this moment, I would ask for an albumin and a prothrombin time. That would be a far more useful answer as to whether my liver is functioning well. So that's why the move away from the term liver function test, although I appreciate it still appears on the clinical portal as that. So these transaminases then, the ALT and the AST, generally we associate them with hepatocyte damage. And one thing I will draw your attention to is normal ranges. We feel, and the royal we, that 30 for men and 18 for women would be normal. Now, depending on where you work in Wales, I've seen levels of up to 50 being normal. And certainly I've seen plenty of patients with significant liver disease with so-called normal transaminases. So there's one issue. One, they're probably not great at measuring liver function. And also, depending on the normal range, you can have disease. And equally, the opposite is true. You can have abnormal liver tests with no disease. So these things are different. So young, I often say to people, a teenager should have maybe an ALT of maybe no more than their years in age, sort of 17, 18, something like that. And many patients who have viral hepatitis will have normal range ALTs. So these are obviously, they're useful, of course, and we use them all the time. But I think what I'm trying to convey to you is they need to be interpreted with caution. And many people with liver test abnormalities, actually, when we do biopsy them, have very little to find. Now, one of the banes of my life, and when a GP WCP referral comes through with a raised alkaline phosphatase, my heart sinks, because to be honest with you, this is very common. I try and bat it to somebody else because obviously it's so non-specific, but usually I have to take it on. So alkaline phosphatase very commonly abnormal, and I would say more commonly than not associated with other stuff other than the liver. Obviously in general practice you'll see more pregnant people than I do, but the placenta produces alkaline phosphatase, bone produces alkaline phosphatase. There's a huge variation in age. It can certainly reflect biliary disease and cholestasis, of course it can, and in the only setting I find it useful at all, a gamma GT can be useful in helping there. I used to ask for isoenzymes. I tend to find now the laboratory blocks that and tend to suggest a gamma GT. So I don't use gamma GT at all. I see a lot of people in primary care and in substance misuse. They're big fans of the gamma GT. It's not now a routine liver test. It used to be back in the days of the SMAC. I don't know if any of you remember SMAC. It used to be this biochemistry thing that gave you everything. The problem is it goes up with the wind. It goes up in anything and everything, and can be very, very non-specific. The only place I find it of use is if I have a raised alkaline phosphatase, then a gamma GT may help. I'm saying may because obviously if alkaline phosphatase is up due to inflammation, then the gamma GT may be up as well. People often use it as a measure of alcohol misuse. I don't really. And it is apparently the most common liver test abnormality in non-alcoholic fatty liver. So it's a pretty useless test, but I do see a lot of people in non-liver practices use it. So the other one is bilirubin, obviously major liver test. Can look at hepatocellular damage or cholestasis, but there are lots of other things. At least seven, I don't know, half a dozen referrals a year reflect Gilbert syndrome, so isolated raised bilirubin. Certain drugs can give it. Fusidic acid is the classic, you get isolated bilirubinemia, but it is a measure in many ways of hepatocellular damage and cholestasis. So those, I think, are what I would call liver tests. So the ALT and AST, the alkaline phosphatase, the bilirubin, and the gamma GT. I don't use gamma GT. So these are the things on the ward and in the clinic that I would really be looking at. And so I'd probably add the bilirubin to this as well. So the albumin, again, it's not specific. You can go in other things, but certainly it's a good idea if your liver's not working well, you're out in the outpatient clinic, an albumin of 24, and you think, oh, there's something not right here. Obviously, if you're in the hospital and someone's had burns, you've got nephrotic syndrome, you've got gut failure, but of course, you know, they're more obvious. But in the right setting, the albumin's a really nice measure. And with these graphs we get on Welsh Clinical Portal now, you can often track the albumin dropping down over a protracted period. And then prothrombin time, or INR, is again very useful. There's lots of confounding factors. Of course, if you've got cholestasis, or if you've got warfarin, or even the DOACs, I don't care what they say, DOACs definitely change your clotting string because they're all a bit up. But it is very useful functioning test of your liver. So I'm milking this point slightly, but hopefully the paradox of hepatology is liver function tests do not reflect liver function. I used to use this analogy when I first started. My wife had quite a cronky car back in the day. It did very well, many happy years, but it looked like it looked bad. I'm very mindful not to swear because I can't see the audience. The car looked awful, but it did very well, and it got her to work, and it got us, the kids, to football. So the paradox is that the car looked awful, but it worked well, and that's the paradox of the liver tests in many ways. That a liver can look good, and the liver tests look good, but actually underneath it's bad. So that's why I think if you think of this car, try and interpret liver tests with caution. I would avoid the term liver function test, although I accept that's what's on the clinical portal. So what's useful and what's for? I often find that we get lots of referrals, and I often find that my colleagues in the hospital who aren't predominantly interested in the liver really are, not clueless is the wrong word, but disinterested. You often get referrals, abnormal liver tests. So what do you do? So I think, like anything, you've got to have a plan and start with a patient, not the liver test. And I think what you've got to try and do is look at what do these tests mean? What's the ultimate? What does it reflect? Anything? Does it reflect nothing? And does it reflect any significant underlying liver disease? So I presumably confused everybody because we're talking about liver function tests, and I've said they don't exist. So think liver tests, not liver function tests. Think of non-causes of liver diseases, and often this black and white cholestasis versus hepatocellular pattern isn't really that useful. So how do I approach abnormal liver tests? And there'll be those of you who sigh and those of you who jump for joy when you see that as a physician that the history is really key, and the history is really key to explaining abnormal liver tests. the number of times you've had that eureka moment when the patient goes, and the doctor gave me flucloxacillin, and then you think, well, that's it. And so history is absolutely vital. So with the history, you can usually tie things together. So if I had a young lady now from the Gwendraeth Valley, maybe one of Nicola's patients the other day, been feeling unwell for a couple of months, non-specific, bit of an ache in the right upper quadrant, transaminases are up. Long story short, she's got autoimmune hepatitis. We often see people then who come in with right upper quadrant discomfort, episodes of nausea at night. So the history is absolutely vital and key, absolutely key. So symptoms, looking for any viral prodromes, any autoimmune sort of feelings. Cholestasis is usually quite easy to spot. Nausea is the top symptom, I think, more than pain. People waking up in the middle of the night with really bad nausea and sweating. I'm sure you see this more than I do. People's age is really important. Hepatitis E, for example, is a middle-aged man's problem. CMV and EBV is a young person's disease. Jobs aren't so much important anymore, but obviously you get exposed to stuff. Travel and contacts are important. Medication's got to be top of the list. So taking a good history. We had a woman, again from the Gwendraeth Valley, from Pontiers, who'd taken some herbal remedy for her liver and given herself acute liver failure. I think it had some marshmallow root or something. So always ask those history, medication, family history, transfusion. Sorry to pick on Ponteberem, but I had a woman from Ponteberem who had UC, had a transfusion in 1988, abnormal liver tests, subsequently turned out to have Hep C. So these are really important things. So you're looking at the symptoms, the chronology, what's been happening, past medical history, obviously with regards to probably the most important thing, UC, which is non-alcoholic fatty liver. So looking at coexistent diseases like diabetes. So examination is useful, but less useful, I think, than the history. There's obviously the classic signs we all see for chronic liver disease. That's easy, isn't it? When things are obvious, it's easy. I think it's the people who you find with abnormal liver tests are probably the ones that give us the biggest headache. Cachexia and weight loss associated maybe with cholangiocarcinoma or hepatopancreas cancer. The other thing I put in here is heart failure. Heart failure is a bit of a catch for us because it gives us sarcopenia, it gives us ascites, and it gives abnormal liver tests, and it can give the features of cirrhosis. And that's probably why I put that in there, but I'm not going to digress because I promise I will try and keep to time. So using the history, and I would say history, and then using the examination and the liver test to help, you should be able to get an idea of what's going on, really. And liver tests, a bit like an ECG, isn't it? An ECG without the story is meaningless, and liver tests without the story is meaningless. We know that not all liver test abnormalities reflect liver dysfunction, and hopefully you'll have the image of that car in your mind. And in the correct setting, maybe albumin and prothrombin time are better ideas of the functioning of the liver. So the textbooks will tell us these things, isn't it? That if you've got a hepatocellular damage, for example, in viral hepatitis or in autoimmune hepatitis, then the transaminases and the bilirubin are raised. In cholestatic diseases, things like gallstones, pancreas cancer, primary biliary cholangiopathy, drug-induced cholestasis, then it's the alkaline phosphatase, the bilirubin. I've snuck in the gamma-GT there as well. The prothrombin can be up in both of them because you remember that if you've got a blockage to your flow of bile, you can't absorb vitamin K, which is one of the fat-soluble vitamins, so you get a slightly raised INR. So again, I'm not going to labor this point because you probably all know this, but the rule of thumb that I've got, if your ALT is up, it's one of three things. At 1,000, it's going to be shock. And that's quite common in the hospital. So people have had maybe sepsis and they've had hypoperfusion, they get acute tubular necrosis, they get acute liver ischemia, and then you get an ALT that shoots up and shoots back down. Toxin, so probably the commonest thing we see in the hospital is paracetamol overdose. Your ALT can shoot up. And the other thing then would be viral hepatitis. So things like Hep A, not that you see an awful lot of that, Hep E for egg, CMV, EBV, Hep B, occasionally Hep C. So those are the things you think about when they're up in the thousands. Then the commonest ones we see, I suppose, and I mean we as in all of us in this seminar now, would be in the ones maybe in the 100 or hundreds, and that's where the majority of the things lie: medication abnormality, non-alcoholic fatty liver, alcohol-related liver disease, and stuff like that. And similarly, those that are just a couple of times the norm. I don't ignore that, although I seem to have gone down in my tone of voice as I've gone from 1,000 to 100 to 10s. Equally, someone with an ALT of 40 needs it explained as much as someone with 400. But the time scale is important, and the lovely graphs we now have in Welsh Clinical Portal allow us to look at the chronology of things, which is lovely. It saves drawing graphs. So if I have someone with an abnormal liver test, I make no apologies for doing a liver screen. The history is important, but then liver screen. So I would do viral hepatitis. So you get A, B, and C for nothing. In the right context, if someone's got B, then you may want to do D, but I wouldn't do that routinely. Hepatitis E is the commonest acute hepatitis that I see. Classically affects middle-aged men, to do with probably unwashed veg or pork, it's unclear. And then in the right setting, I would do CMV and EBV. I would note caution, I've come across two 40-year-olds with acute CMV in the past 2 years, and they were both people who'd married fairly young and then had marriage had fallen apart and met new partners, obviously been exposed to a virus they had never seen. So that's interesting. But in general, EBV, CMV are picked up in late teenage, early 20s. Autoimmune disease is always common. It always trickles. You've always got a few people coming in. So ANAs, the liver antibodies, they all come on the screen. Immunoglobulins as well. Then there's the metabolic diseases. You're all familiar with alpha-1 antitrypsin, hemochromatosis. And again, you always check for copper and coruloplasmin, but the lab will cut off at about 40. It is as rare as hen's teeth. I've got one woman in Llanelli I inherited from Mike Dew, and there was one who moved into the head injuries unit, but it is rare, rare, rare. I'm not going to talk about what's at the bottom of the slide there. I think I took that from another thing. That slide's basically my whole job in a slide. Sorry. So with regards to alkaline phosphatase and cholestasis, I've put these little pictures on because I often say to the students, you've got to think of cholestasis from the top to the bottom. We always think of the bottom, we think of head of the pancreas, cancer and stones. Yes, that caused it, but you've got to take it all the way back to the transporters. So these are the little things that transport bile from the cell into the ducts, and things like obstetric cholestasis and drug-induced cholestasis operate at that level. I don't know if you can see the arrow, maybe you can, but if you think of these cholestasis all the way from the top all the way down. Primary biliary cholangiopathy, for example, is a small duct thing, but the outcome is the same: dark urine, pale stools, itching, jaundice. The commonest things, of course, are stones and tumours, sadly. And again, the history is useful. What is interesting as well, sometimes you get an acute viral hepatitis, and after you've gone through the ALT shoots up. As you start to improve, you go through a cholestatic phase sometimes. You get some slightly cholestatic features, and presumably that's just the liver being unhappy. Part of the problem is, for you in primary care and for non-liver clinicians, is it's a really confusing field. You'll have gone through loads of talks like I've just talked now about ALT and doing the liver screen and all that. That's fine. Part of the problem is there's lots of different guidelines. It's often excessive, and what I put at the bottom, probably the reason for this talk, I guess, is probably what do you do, what tests do you do before referring on. And this is where my difficulty is, because I don't know if there's how old are GPs other than Nicola there, but I will often say, if you've got abnormal tests, just refer. I don't mind, I'll just see them. Now, that is not something that I can say for all my colleagues across Wales. I'm very conscious this, I don't know where you're from, presumably you're all over. So if I just say refer all your normal liver tests, I'm likely to get a real kicking at the next meeting. So there are guidance, but I accept it's confusing. I did a quick search now, because what you're asked to do is some of these rather poor non-invasive tests, which are many. This is just a selection of few. I put a FibroScan at the top because that's the one I used. You've probably seen these things, the ELF test. FIB4, BARD, the AST to ALT ratio, NAFLD score, APRI. And these are all fairly straightforward. ELF is probably not straightforward because you need lots of weird things you can't get hold of. Well, P3NP is one of them. But the others you can do from, you know, the data that we've got, clinical or laboratory tests. And I think it is confusing, but I am going to stick to the party line, and I'm going to first go to the BSG guidance, which I think is in conjunction with the Royal College of General Practitioners. I hope this projects well, because the ones for all Wales does not project well, and I've asked Nicola to send that out to you separately. I think basically they all say the same thing, that history is, and I'm glad to see at the top that history is important. I would echo that. And again, you go into this pattern recognition, you know, in many ways, yeah, it's all right. If things are obvious, it's obvious, isn't it? But if they're not obvious, then the patterns are less clear. I think what you will see is if you suspect the person's got alcohol-related liver disease, then you go to a different pathway. And again, that's confusing. You're already switched off. I know if you've switched off, but I'm thinking, oh my God, this is a load. And then you go down the route of, you know, are the ASTs up? Right, okay, let's get an ultrasound. Let's see how high it is. Do I need to repeat it? And I think I could talk you through the thing, but you can see, but you've probably seen this all before, but it does involve maybe looking at an AST or an ALT up, thinking, oh, this is hepatocellular damage. I don't know if you can see the arrow here. And then going on to do the liver screen. Is it NAFLD? Are there risk factors for it? Let's do a score. And then if it's not, let's do an ultrasound. And to my mind, and part of the problem I find, I know you can do this because anybody can do it, but how much time have you got to do this is my concern, which is why I've always said to my clinicians in locally, listen, you've got abnormal, let's just refer them. You know, it's not a problem. I can do this. I think the problem with these scores is they're all right. They're not brilliant. They're just all right. And my personal feeling is that it's more of a sort of rationing service of who gets referred and who doesn't get referred. Anyway, I'm not going to get distracted. Looking at liver function, isolated bilirubin, so there's a whole thing on Gilbert syndrome, and then there's cholestasis, looking for things. But it's fairly straightforward, but it's a bit of hard going. I downloaded the NAFLD one then, and I think this is where it becomes complicated, or not complicated. I don't use any of the scores. I just use a fiber scanner. So when people come to me, I make a diagnosis, and then I use the fiber scanner as our risk stratification tool. So yeah, I appreciate you don't have that in primary care, but I think these things are fine. You know, you can do a FIB4 test, you can do a NAFLD things. They're all available on your phone on MedCalc, and they're all right. You know, it gives you an idea of what's going on, and it may give, I see some referrals coming through with these numbers on. But I think if there's any concern, or you know you're not happy, then I wouldn't have a concern. I suppose if you work in other parts of Wales, you may wish to follow this pathway a bit better. But the NAFLD one, this is, to be honest, this is the most common thing you're going to see. NAFLD is the most common thing I see in clinical practice. So the other one is alcohol-related liver disease, or alcohol-related abnormal. We use this thing called the Audit C. I'm not sure if you do. There's an a shorter version, abbreviated version, which is quite useful and allows you to triage people, and obviously refer on then to various tests and more importantly services which are able to support them. So these guidance here are what has come out from the BSG in about 2017, 2018, and I can see that they're on the Royal College of GP website, and I've seen this, and I think there is a GP, and I can't remember her name, she was involved with the BSG as part of this, and they're good. They're very good. The only thing that worries me in primary care, where to be honest staffing seems tricky, how much time you've got to go through all this, I'm not sure. So Wales have got one, and you won't be able to read this, but I have asked Nicola or Hilary actually to send it out. It's got these QR codes on the side, which are quite nice. It gives you update, but it basically says the same, and I apologize for it being so awful to read, but it basically, take a history, how high is the transaminase, do some scanning, do some form of risk stratification, and then refer on, or just keep an eye on them in primary care. So I'm guessing, and it is a guess really, that is the crux of the problem is, oh my God, which FibroScan, what do I do? Do I risk stratify? Do I just refer? No one's come back to me on the question thing, but that would be my, if I was in primary care thinking, oh gosh, what do I do? So I think the thing is, don't lose focus on, because the question is, why are the liver tests abnormal? Do a history, do a screen, be aware, a bit like liver tests, the non-invasive tests are not great. If you've got cirrhosis, they're good. If you haven't got cirrhosis, they're good. But the truth is, most people are in between, and therefore they're not great. Even the FibroScanner isn't great, and even a liver biopsy isn't great. So it's all about, using what you've got. So I think the ELF is very good, but I don't think we've got that. We haven't got it available here. It involves hyaluronic acid and P3NP and some other thing. FibroScan's good, and we can certainly do that for you. I don't just do a FibroScan, because obviously, as I've laboured, assessment of liver tests involves history, examination, and tests. So people often refer, can you do a FibroScan? Well, I can, but I'm not going to. I'm actually going to speak to the patient and try and get a picture. The other things like the NAFLD score and FIB4 are fine. They're cheap, they're cheerful, they're easy to do. You don't need any fancy tests, and they help guide. So I think they're very reasonable, and they help to build a picture. So in order to bring to a close, I guess, this part of the talk, guidelines are important. If nothing else, they highlight the importance of not ignoring liver tests. When I first started as a consultant, I went to a diabetes talk in Carmarthen. I was told by a very senior GP, oh, if I referred every abnormal liver test to you, your clinic would be swamped. Now, that may be true, but equally, how many people have got cirrhosis that weren't referred? So I think I would rather have a swamped clinic, and it becomes my problem, than people left not having things explained in primary care. So it highlights the importance, and I think the clinical method stands, doesn't it? We learned it 30 years ago in medical school: history, 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 and that is what's going to give you the most diagnosis. You've got a man coming in, he's been an IV drug user, he's got transaminase of 40. Well, he's got chronic hep B or C until proven otherwise. It's not a judgment, that's using history and your knowledge. The liver screen is important. I do a liver screen on everybody. It's available on the Welsh Clinical Board. You just go to gastro liver screen and you get everything. Ultrasound's important as well. So the other thing I think where we all get a bit tied up is risk stratification, because what you do these liver tests mean anything? So a lot of people have just abnormal liver tests, bit of fatty liver, but they are fine. They need lifestyle advice, they need risk factor managing, blood pressure, cholesterol, diabetes, but liver-wise, they're fine. So we can use the FibroScanner, we can use some of these non-invasive tests, but I really do feel that crosses the interface between primary care and liver services. I'm more than happy to do that locally. Again, I don't think that can be replicated across Wales in certain hospitals which are big and busy. We may be a bit privileged down in the West. But I think we do. I think the strategy is, because the number of liver tests is abnormal, there is need for strategy, and that's why hopefully Nicola's emailed you or blackboarded you those guidance that have come from the Wales Liver Panel. Right. So I don't know whether you want to stop there, because we've stopped a little bit early, but just if there's any questions. Seeing more abnormal than normal passing through results in books. Yes. Yes, it is. I think the problem is that people are living longer. People are fatter and more metabolic, and I think more people are having medication. I think that's probably the issue with abnormal liver tests. I don't hold with this, and I'm sorry, Maya, I'm not having a go at you, but would you not treat somebody's blood pressure just because lots of people have high blood pressure? And that was my argument to a very senior GP in Carmarthen. Is it okay to ignore stuff? I don't think it is, but then I wouldn't, because this is my hobby horse. Do you stop treating blood pressure when you've treated 100 if there's 200? I think if there's a liver test abnormal, it needs explaining. I'm not saying it needs, well, I can't say it's clearer than that. It needs explaining. Otherwise, are you going to turn around to that patient in 20 years and go, I'm sorry, I didn't check you for hep C because it was a cure for hep C, but oh well, it was quite busy. So I think if there's abnormal liver tests, it needs explaining. Jonathan Matthews, is there any benefit in repeating liver tests? Yeah, this is a really good question. I think it is on the guidance that you should repeat it. So the story is, if liver tests are up in primary care and they're up the second time, there's almost an 80% chance that they will stay up. It's very different in hospital practice, where people come in with sepsis or they're given drugs. Liver tests often come up and down. I've had 2 recently on the orthopedic order. I don't know what they're doing there, but the alk phos have gone up to about 600 or 700. One patient from Whitland, I don't know if the GP's on from Whitland. 2 patients, just alk phos shot up. But in primary care, if your liver tests are up and then you repeat them a couple of months later and they're up, they're unlikely to go down. So yes, you're quite right. On that guidance, which we can't read, it does say to repeat it. So Maya's come back to me, agree, but we do need more funding and better liver service. Yes, and I agree with you, Maya. I don't know where you work, Maya, but certainly there's an All Wales liver delivery group, and there's a lead liver physician in every hospital, in every health board. Betsy's good. I mean, you've got Mutti up there, haven't you, up in the top east. Yeah, I mean, we've got lots of money coming now. Well, not lots of money, but there's liver nurses, there's FibroScan nurses, there's lots of things. But I think in a busy practice, if you can do the basics, I think that would help them. Again, I am conscious that you've got lots to do, and the staff is tricky. Zahara, mild fatty liver and ulcer, what would you recommend? Yeah, that's a great question. I get that. I get that. Oh gosh, there's too many questions coming in there. With regards to fatty liver, this is a really important thing, because this is the most common reason we're now seeing for end-stage liver disease. So what I do, someone with a fatty liver and ultrasound, I bring them in. I take a history. If it fits with fatty liver and there's fatty liver and ultrasound and the liver screen is negative, we do a FibroScan. The FibroScan's normal and they're quite old, then we just give them lifestyle advice and get rid of them. If they are quite young and the FibroScan is normal, I'd probably bring them back in about 3 years to make sure that it hadn't progressed. And obviously if the liver FibroScan is abnormal, suggesting of fibrosis, then obviously they get slotted into liver clinic. I guess in primary care, your options are either to do those NAFLD score or the FIB4 score, or to refer on. But I think it's not acceptable, I think, because the other reason, fatty liver, you can get alcohol. Chronic hepatitis C type 3 gives you a fatty liver. So it's always worth explaining it. And I think we all used to ignore it years ago. We go, oh, a bit of fat on the liver, don't worry about it. But I think we should worry about it, along with all the other things you've got to worry about in primary care, postmenopausal bleeding and headaches and all the other stuff. I am conscious that this is my baby and you've got lots to do. So Paul, Joel, there are consistent guidance for timetable for repeating beyond 3 months for safety net. Are there consistent guidelines? I don't know. I think what the All Wales guidance said, I probably got it here, did I print it out? It says do it and repeat it in 2 months. I think once you've explained an abnormal liver test and you've done the risk stratification, there's probably not much point in repeating it then. Because if it's abnormal, it's going to be abnormal. I think that's probably what you're asking. It's quite good, this, because you can't come back to me. That's quick. No hecklers. Jane, then, thanks for your presentation. Oh, that's a fine, good start. We get a lot of slightly abnormal ALTs in primary care. If the flavour is of fatty liver due to obesity and diabetes, I usually tend to have a good chat to the patient and try and reverse and optimize weight. Yes, that sounds very good. Then repeat in 3 months. If coming down, tend to just monitor. If going up, I would tend to go a liver screening. Well, that seems very reasonable. Yes, I think so. What Jane's saying is that if it looks like fatty liver, and it probably is, lifestyle intervention. So if you've got fatty liver, the relative risk is 15 for dying of heart attack, stroke, diabetes, related complications. Your risk of dying of liver death is 2. So if you're a betting person, you're going to die of a heart attack or a stroke with a fatty liver, not liver failure. So you're quite right. Addressing the risk factors is the way forward. I think if things haven't changed, and I think in many ways we think they probably won't change, then doing a screen and ultrasound seems particularly reasonable. And probably I would add to that a non-invasive score, again, depending on where you work. Thanks for your presentation. I have been seeing a few cases of incidental mildly raised transaminases with no clinical symptoms. When can we repeat? So I probably, as well, I can't remember who it was. Somebody earlier on said, I think repeating in Jonathan said, I think repeating in about 2 to 3 months seems reasonable. Again, it's on that guidance, which I can't read. It may even be less than that. But yeah, these are the things, you know, slightly raised transaminases. You can't ignore them really, just in case it is something, because the problem is Hep B is so treatable. Hep C is curable. You know, you don't want to miss those things. They're you know, autoimmune hepatitis is usually easier. So, but you can have disease with just slightly abnormal liver tests. You know, hemochromatosis is the other one, isn't it? Very, very treatable. Sahara, if ferritin or B12 is raised, ALT is normal. Is it worth? Oh gosh, no, probably not. So what Sahara is saying is if your ferritin is up, and this is a very common referral, you might try hematology. Hematology says it's reactive or liver. So I think history is vital here. So if people have got an unhappy liver from drinking or maybe fatty liver, the ferritin can be up. In hemochromatosis, you get high ferritin and high transferrin saturation. So you're looking at levels. So ferritin greater than well over 1,000 anyway, and transferrin saturations 70, 80, 90%. You can sometimes see that in drinkers, but very rarely. The commonest picture is a high ferritin with a low transferrin saturation. Zahara, I don't think I would pursue liver. I would certainly pursue a history, and I think if there is something to support maybe a fatty liver or alcohol, then an ultrasound would be reasonable, and it wouldn't be surprising that you'd find a fatty liver. It's worth noting that 50% of patients with fatty liver have normal liver tests. There was quite a nice survey in Nottingham GPs. You may be aware that where we went in and looked at people who drank too much, and I think people who had diabetes, and a lot of those had fatty liver, irrelevant of their transaminases. Eleanor Williams has put her hand up, but I don't know how to respond to a hand, I'm afraid, Eleanor.
Hi, Eleanor. If you just write your question in the chat box, then Ian will be able to see it.
Okay, right.
I don't know whether we want to do some quick cases. Have we got time? Everyone likes a case. Should we do cases? Once Eleanor's typed, how quick you can type. You can always tell the GPs that type. The referrals are about half a page long. Those like me who can't type, it's like four lines if you're lucky.
Yeah, I think if you want to just go over a couple of the case studies, then we can come back to the questions at the side if there's still some time at the end.
Okay. Well, I don't know if there's any Gwendraeth Valley GPs. I've got nothing against the Gwendraeth Valley. My family were born and bred there, but there seems to be a rich picking on the liver front. So this is a real case a couple of years ago. 70-year-old chap, ex-miner from Trimsaran, came feeling unwell for about a week. He felt nauseous. He was jaundiced. So I appreciate you can't all answer. So obviously the approach is to take a good history. Nothing really, not a drinker, no tall and thin, ex-miner. So we did an ultrasound and we did some liver tests and liver tests, so the bilirubin. So he's got jaundice, he's got a hepatitis. Now you would remember earlier I say if the ALT is about 1,000 or so, you think toxins, you think shock. Well, he wasn't shocked. There was no obvious toxins in his medication. Hadn't taken an overdose. So we think then of viral hepatitis. So in a man of this age, Hep A is unlikely because he's probably either been immunized or he's had it as a child. And he had acute hepatitis E for egg. The IgM and the PCR was positive. Surprisingly common. Part of the reason we don't pick it up is that the lab are a bit reluctant to do it unless you ask for it. There was a time they wouldn't do it unless your ALT was over 500. But it's a common thing, self-limiting disease, can be troublesome in immunosuppressed people or in pregnant women, but quite a common disease, certainly more common clinically than hepatitis A. I can't remember these cases now. 60-year-old woman, overweight, presents with an infection, not septic. Gosh, I can't remember. I moved to, so the ALT is a bit high, isn't it? Certainly higher than I would expect for non-alcoholic fatty liver disease. Definitely higher than alcohol. She's presented with an infection, right? So the history would really go along with is this biliary sepsis. Prothrombin and bilirubin's normal. The surgeons, oh gosh, the surgeons. Oh, the bilirubin's normal. There's nothing going on. That's absolute tosh. So a number of people I've seen with gallstones with a normal bilirubin, you know, surgeons. I hope there's no surgeons on. Anyways, this woman had an ultrasound. The common bile duct, which should be 7, was about 9. But then the ultrasound again comes back, oh, there's nothing there. Again, if the story is good and you think this woman's got biliary sepsis, then go ahead and do an MRCP. And that's what we did. So very often the ultrasound, it's good, but it doesn't show stones as commonly as we think. If there's any suspicion, I'll do an MRCP, and you often find stones lurking there. So that lady was, again, the history was what guided us there. Oh, the answers there. So 25-year-old drug abuser and drinker. Again, transaminase is normal. Well, I don't know what the normal range is, but certainly I've said to you that a man should be about 30, so it's up. But the history is key here, isn't it? That he's got abnormal liver test. He's been a drug abuser. He's got chronic hep C. So hep C is curable with 2 to 3 months of 1 tablet a day with a 95 to 100% cure rate. So it's, hep C is worth having now. And again, I've had a case like this very recently, actually, another girl from Pont Henry, but she was 40, just generally feeling unwell since Christmas. GP did a load of bloods because she was feeling unwell. ALT was 500. In this case, the other lady, she had a positive ANA. Interestingly, her IgGs and liver antibodies were negative, but the history was really good for autoimmune hepatitis. So a bit like this lady, I've done a liver biopsy, it shows interface hepatitis. We've given her steroids on the day of the biopsy, and within a week her transaminases are normal and she's feeling better. So again, you don't want to miss that, because autoimmune hepatitis responds so well to immunosuppression. If you miss it, it can proceed to cirrhosis at quite a lick. Right, so it sounds like I'm being judgmental, but these are real cases. I think I'm going to just cobble them together. So a young person found unwell, ALT is 2000, so it makes you think of toxins, hepatitis, or shock. Well, the patient's not shocked. Well, they are shocked, actually, low blood pressure, so it could be a few things. But the things to think about are rehydrating the patient, reversing the shock, but also, because they're unwell, doing a paracetamol level and thinking of, well, giving N-acetylcysteine, and that's more of a secondary care thing. Again, this is a secondary care thing. Since the antibiotic police have stopped us using coamoxiclav, we've had a bit of a reprieve, but coamoxiclav, flucloxacillin, some of the DOACs, lots of antibiotics will cause drug-induced liver injury, very common. The rheumatologist and the dermatologist keep me practically in business with abnormal liver tests. Again, the history is key. Person in hospital, given antibiotics, turn yellow, and then you can see the graph. So history is king there again. I think that's it, I think. Right, summary. So common liver tests are a poor reflection of real synthetic function. The alkaline phosphatase, alk-phos, gamma-GT, bilirubin are the commonest ones, but they've got lots of differentials why they're raised. And beware of what's normal. Some of the normal ranges may not be normal. Think of 18 and 30 more than think of club 18 to 30. That'll stick in your mind, isn't it? I don't know if that's still going, is it? 18 to 30. Look for a pattern and take the history. Have a little checklist in your mind for what things you should look out of. I do think that's it then, Nicola.
Thank you. I think there was just one extension to a question from Razak about hepatitis C current regime, which you just mentioned, but asking, can they be treated in primary care whilst awaiting an appointment?
Oh, that's a great. So if you're Scotland are about 4 million light years ahead of us. So in Scotland, you go into, if you're a drug taker, you can go into a pharmacist, have a finger prick test, which tests you for PCR positive. That comes back in half an hour. You're then given a bag of antivirals and sent on your way. So that's the level of what's going on in other places. They're really expensive is the problem. The drugs are like 30,000 or 20,000, so that's part of the issue. So they do tend to come out to secondary care, and they do tend to come on home care because we save the VAT. I'm not really answering your question. So they could be treated in primary care, but they're not. I think probably due to the price of the drugs. We do a bit of risk assessment. You know, we check for other viruses, and we do an ultrasound, and we do a fibre scanner. But, you know, should they be vaccinated? Yes, they should be vaccinated as well. So if you've got Hep C, or if you've got cirrhosis, we often recommend vaccinating, because obviously if you get acute Hep A or B on top of your coexistent liver disease, you can run into trouble. Yes, in answer to Zahara, so if you've got these, Twinrix is what we recommend, and you give these vaccines, and the main thinking is that you don't get another insult on top of an unhappy liver. I'm not sure if I answered all the questions there.
Yeah, any last questions? If you can pop them on the chat line now. I'll give you a few seconds to see if there's anything more. Lovely. No, that seems to be it for now. Thank you very much, Ian. Hope everybody feels somewhat clarified, and we'll all refer to them as liver tests from now on. I can just see that Zara's come back in saying she was meaning in healthy patients with no liver disease, should they be recommended hepatitis A, B vaccinations?
Oh, no, I don't think so. No.
We've had another question in from Razak. What treatment would you give to pregnant patient with Hep E?
That's a really good question. I don't know the answer to that because there's no specific treatment. I think it's more of a problem in other parts of the world, particularly around sort of floodplains. I got a feeling sort of Bangladesh area where they get lots of flooding. The answer is I don't know. I'm sorry. Certainly in this country, the treatment is supportive, and the disease is generally self-limiting, except in people with immunosuppression. And I guess, again, I am guessing now whether there is some role for some of the antiviral agents, but I don't know. So I'm not going to say anything on that. Sorry.
Well, thank you very much for your talk, Ian. I'm sure it's certainly going to help me, and I'll try not to send so many from the Amon Gwendraeth Valley up to you now.
Well, you've got an interesting cohort there, Nicola. Yes.
Okay, thank you very much.